Hello, my name is Dr. Varsha Rathod. I'm one of the physicians here at Palm Health, and I'm really happy to bring to you the webinar on sleep today. I've done a similar webinar last year, but this one is just a little bit different because I've brought in a new book which has more clinical correlation. So let's get started. To start with, I'd like for you to take a moment and measure what is known as your sleepiness score. Normally, your score should be between 1 and 3 when you're not having a great day. If your score is higher than 9 or 10, then you definitely need to get more sleep. This is known as the Epworth Sleepiness Scale. All right. There are 3 books that I refer to, and I have to thank Institute of Functional Medicine for some of their slides, as well as the authors Matthew Walker, T.S. Wiley, and Chris Winter for their books and the contents of their books that led me to make some of these slides. Each one of these books had a major influence in my understanding sleep, because this is not something that we learn quite well in medical school. The first time I actually did any out of medical school reading about sleep was in the book called Lights Out. I met T.S. Wiley at a conference in 2006 or 2007. It was a hormone conference on menopausal hormones. And I was talking to T.S. Wiley about my own hormonal menopause that was impending. And she said, "Oh, you should read my book, Lights Out." And I did, and it was one of the best books on sleep that I'd read in a long time. Actually, it was my first out of medical school book on sleep. This book is really good because it helps you understand the role of light, sleep, and how it governs our metabolism, which is basically saying our hormonal function, hunger, and weight. So it's really good at it. It also is very good at describing a phenomenon that has been on the rise called polycystic ovary syndrome. This is a condition where young girls have their ovaries pop cysts after cyst after cyst. Some of them are skinny girls and some of them are overweight. Usually they start off being skinny and they get heavier. And the reason for this is light stress. So these girls are texting late into the night, doing their homework late into the night, and the light pollution that is happening to them is disrupting their endocrine system, leading to the body being under physiological stress. It's very interesting when the ovary is under physiological stress. It is the only organ, the only system in the whole body that knows to be sensitive to the stress. In other words, it will start to pop eggs out, whereas all other organs like your muscles, your brain start to slow down. And the reason for this is human evolution, or the propagation of the human species. If you do not propagate, the human species dies. So that's why the ovary starts to pop out these cysts that you can get pregnant. Isn't that ironic? Then Matthew Walker was the next book I read, and he is very, very good at making you understand why we sleep, the power of sleep, and also looking at anthropology of how humans moved in tribes, and therefore when you move in a tribe, you have to have protection for the other humans who sleep. So there became some humans who became watchers of the tribe, night watchers of the tribe, and then they are the ones who then genetically or epigenetically evolved as becoming night owls. And the others were possibly somewhere in between morning larks or morning doves, however you want to call it, or a mix between the two. He also is very good at making us look at animal species and how animals sleep. For example, we ever seen birds in a wire sleeping? So how do they protect themselves from, say, another bigger bird or vulture coming and grabbing them? The way this is done is the birds at the end of the line have 180 degrees vision on one side and this on the other side. So only half their brain is sleeping because this side of the brain is sleeping, whereas the other side is not sleeping. Halfway through the night, they turn around and the other half of the brain, so they'll go 180 degrees opposite and let the other side sleep. Very similar to how dolphins have to come up to the surface to breathe or to fish to swim. They'll use half their brain for the first half of the night and use the other half of the brain for the second half of the night. So that's Matthew Walker's book. And it, of course, he talks about the sleep disorders and CBI, etc. And then my favorite book of late is Chris Winter's book. Chris Winter is hilarious. He really does a good job about making you understand sleep and also taking that clinical interest in the patient with insomnia who often gets left out of the picture and making you understand what it really is. So in this webinar, you're going to learn about how we generate sleep and what are its effects on the whole body, the phases of sleep, you know, the waking stage, the light sleep, deep sleep, REM sleep, basic sleep disorders, how we test for these sleep disorders, and what can we do to help us sleep without the use of drugs? What are the drugs that we can use, and how can Palm Health help you? So there are 4 pillars of lifestyle for good health. The most important ones, nutrition and water, getting enough movement and air, and the topic of this webinar, which is sleep. And then, of course, people and relationships and sex and procreation, because without it, you cannot have the human race. So this is the only slide that's going to talk about metabolism and the total effects of sleep. And to start with, I would like to emphasize that sleep is really not the absence of wakefulness. When we sleep, the body does some magical things. And I can go from organ to organ to describe what happens in every organ, but I'll just give you a summary. Let's start with the brain. Your ability to learn is fostered during REM sleep because it restores memory and also stores memory. During slow wave sleep, or what we call NREM sleep or deep sleep, is when our physiology and our body recuperates. In medical school, I remember actually even till 2015, when I went to an IFM seminar on sleep, we knew that the brain did not have a lymphatic system. So we often wondered how it would remove toxins. In 2015, actually, 2 researchers, independent researchers, found and discovered something that they coined the glymphatic system. Lymphatic system, glymphatic system. And what this is kind of the bilge pump of a ship. You know, when water collects in the bottom, the bilge pump has to pump out the water so that the boat doesn't sink. Very similarly, when you lay down in a horizontal position, the brain and the cerebrospinal fluid kind of pump down the spinal canal. And this is best achieved when you're sleeping. And it's particularly effective when you sleep on one side. So this lymphatic system helps remove toxins of your daily making of energy in the brain neurons, but it also removes a very, very important chemical toxin known as beta amyloid, which is a byproduct of the neurons functioning. Beta amyloid is one of those proteins that cause Alzheimer's disease. So I'm not saying to you that Alzheimer's is caused by our inability to remove beta amyloid, but it certainly aggravates that condition. We've also shown that patients with the ApoE gene form are more likely to develop Alzheimer's disease, but studies have now shown that those that sleep well actually do not go on to develop Alzheimer's, or they can delay the onset of Alzheimer's. So here's a classic example of how the environmental cues can actually interact with the gene to alter your outcome, meaning that you are in control of your circumstances. It also restores the immune system, helps fight cancer. It reforms the metabolic state of the body, especially the hormone called ghrelin, like you're growling for food. It creates hunger. So that hunger hormone is very well regulated when you sleep well. Whereas if you don't, then you start craving certain kinds of food, and appetite and food selection are driven towards carbohydrates because of stress. It also maintains a happy gut bacterial flora. When you don't have a happy gut flora, your immune system and toxin system, multiple systems are disconnected in your body. Sleep is also extremely connected to your autonomic and cardiovascular system, maintaining your blood pressure, maintaining your respiratory rate, maintaining your pulse rate, etc. So in short, it really affects every facet of our health, and one has to be able to sleep well to function well. And this is why when you have insomnia, people get so bothered. It's just a drive that you must sleep. So again, why sleep? Well, for starters, I already told you what it does. But secondly, if you do not sleep, you will die. No, this is true. If you cannot sleep, if you cannot sleep one wink, you will die. And there's one fatal disorder known as fatal familial insomnia. It is so rare that we do not have to talk about it besides this one time. If you get it, you die. So the premise I want to set at the start of the sleep webinar, especially because my focus is going to be in insomnia, one of the most common sleep disorders, is that everybody sleeps. Yes, everybody does sleep. With very rare exceptions, everybody sleeps. Now, your sleep may be altered and it may not be efficient, but you do sleep. Many studies on sleep or sleep deprivation have been done, but none of them have lasted more than 2 weeks long, because you cannot get humans to get sleep deprived without them getting microbursts of sleep. Even the Guinness Book of World Records, who had Randy Gardner had one of the longest sleep deprivation. The Guinness Book of World Records doesn't even recognize sleep deprivation records anymore, because they've actually shown that you get these microbursts of sleep, or you start getting paranoid and you start becoming very delusional. So that's really not called living well. So now let's change our focus to how we sleep, what creates that drive to sleep. So there are two systems that govern when we sleep and when we awaken. One is called the circadian system. So this is how light affects our system. And the other one is known as sleep pressure or homeostatic sleep drive, which is driven by the neurotransmitter known as adenosine. So without further ado, the electromagnetic spectrum is what we call visible light, or VIBGYOR, from violet all the way to red. And while camera vision is what sees VIBGYOR, what I am going to be talking about in this lecture is called clock vision, predominantly red and blue light, and also UV light, which is seen by the eye at a receptor known as the melanopsin receptor. When light hits that melanopsin receptor, clock vision is triggered, which then regulates our human clock. It's not just the eye that sees, the skin also sees. And how does it see? It sees by absorbing UV light, so it can actually destroy melatonin in your body. So here's a graphic of how when light hits your eye through the melanopsin receptor, it sends a signal through DHA and water to the suprachiasmatic nucleus. And this is where our clock genes are located. Clock genes are oscillating proteins. And when they start to oscillate, the wakefulness cycle begins, and that's driven by a hormone called orexin. This then talks to various areas of the brain and says, hey, it's 8 o'clock, it's 8 o'clock, wake up. And the same signals are also sent to every organ in the body, and all the brain and every organ in the body should be on the same time clock. If the pancreas is at 10 o'clock, when your brain is at 8 o'clock, you're kind of in jet lag. There are other factors that govern these circadian rhythms, not just light. Temperature, when the temperature gets cold, we tend to get sleepier. Activity, food, and at times at which we do eat food, and times when we eliminate waste are also ways of maintaining our circadian rhythm. 1998 was a remarkable year in the discovery of clock structure in all living organisms. And that was the year the human fruit fly clock was actually found to be proteins, oscillating proteins called bell and clock. I mentioned this here today because in January, Farm Health launched NAD IVs for anti-aging purposes and other reasons. And one of the ways that NAD works is that it talks to the sirtuin genes. It's actually a cofactor for a bunch of genes known as the sirtuins 1 through 6 genes. And these genes actually regulate the bell and clock oscillating proteins. So if NAD starts to fall as we age, or if we get sick, we don't sleep well. That can also describe why you're so fatigued, but you cannot sleep. All right, so here's the next drive to sleep, which is the homeostatic pressure or the sleep drive. So in this graph, I want you to see the dotted line. The dotted line are the circadian rhythms. They're very constant. So as long as you're sitting in one place, like example in St. Louis, your day and night is going to be around the same time, right? So, and it changes throughout the year, but the rhythm remains the same. We call that process S. Process C. Process S is the sleep drive, and that is a hormone that as you stay awake, adenosine keeps rising. So another way to look at it is, here's the homeostatic sleep drive with the hormone adenosine increasing and decreasing as night goes on when you sleep. Similarly, here's the circadian rhythm rising. And when you see the short gap between adenosine and the least amount of daylight, then you're going to have your drive to sleep. So again, another way to look at it is the shorter the distance between S and C, the more the urge to stay awake. The longer the distance between adenosine drive, the sleep drive, and the circadian drive, the greater the urge to sleep. But here's an interesting scenario. You've got to the strong urge to sleep, but you decided to stay awake because you're wrapping Christmas presents, or you have a presentation to give and you have to start preparing for it, right? So you've beaten your urge to sleep, adenosine keeps rising. Around 4 or 5 in the morning, as your circadian rhythm is waking up, you get this weak urge to sleep, but if you fight that urge as well, your adenosine keeps rising, and then by about 48 hours, you develop an extremely strong urge to sleep. And this is what happens in patients with insomnia. They'll go through 2 or 3 days of not sleeping very efficiently and then sleep so soundly because of their extreme sleep drive. Circadian disruption is not abnormal, but it's seen very commonly in humans. And again, it's because of how we sleep. So phase advanced are people like me who are morning larks. I like to get up early in the morning. So I get up before the sun. And so my adenosine peaks earlier during the day or earlier in the evening. And so therefore I get up earlier as well. You see that? That's called phase advanced. It can also happen when you're traveling west. And this is phase forward. So here people are night owls. Their adenosine happens later at night. The circadian rhythm always remains the same. It's just when adenosine peaks happens later. So in this cartoon, that's a morning dove. And this is your night owl. Remember, night owls are human tribes. They were actually protective to human tribes. All right, this will then take us to the second part of the talk, which is what are the phases of sleep and why should we know what the stages of sleep are? We know it's helpful to know it because you know what happens to us during these stages of sleep, what is important, and also what do drugs do in these various stages. So in this diagram here, you have wake, and wakefulness leads to stage 1 and N1 and N2 sleep, that is known as light sleep. And this lasts roughly 20 to 30 minutes. But always remember that it is from light sleep, stage N2, that we go to deep sleep N3 or REM sleep. If we were awake and we went straight to REM sleep, in REM sleep, there's no muscle tone, so you're paralyzed, and that's dangerous, and that's called catatonia. You'll just suddenly go from wakefulness to losing muscle tone. Or if you go from wakefulness to deep sleep, you've suddenly fallen asleep, that's narcolepsy. So those are dangerous, right? So it has to go in this order. On the right here is a graph known as a hypnogram that's derived from a polysomnogram or an EEG-based sleep study. So every horizontal line is the stage of sleep. So this is wakefulness, here's REM, here's N1 sleep, N2 sleep, N3. So see how you go from N1 to N2 to deep sleep, back to light sleep, REM sleep, light sleep, deep sleep, light sleep, REM sleep, light sleep, deep sleep, light sleep, REM increasing. Note how deep sleep or NREM sleep is stacked towards the early part of the day, evening or night, and then REM becomes more prolonged as the morning gets into play. Okay, and this is the way it should be. NREM sleep is very important for the formation, for the restoration of physiological functions and hormones in the body, and REM sleep is more important for memory formation, locking memory deep in the hippocampus, and also for creativity and dreaming. So to summarize the stages of sleep, NREM stage 1 is that transition from wakefulness to sleep plus 5 to 10 minutes. Then you go to stage 2 sleep. Here your body temperature is dropping, your heart rate is dropping. You start to see these little sleep spindles in the EEG recording, and it can last about 20 minutes. Putting you into stage 3 sleep, where your muscles totally relax, blood pressure further drops, breathing rates drop, but they're all nice and regular. And this is where the deepest sleep occurs. Benzodiazepines actually block the stage of sleep. What they do is they put you into brain depression, and this is where sedation is quite different from proper sleep. And then we also then go to REM sleep. After going back into stage 2 sleep, you go back into REM sleep, and here the brain becomes more active. In other words, it's looking active, but the body and muscle tone is completely paralyzed. It's immobilized. The only muscles that are working are the ocular muscles. So the electro-oculogram measures rapid eye movements as you're dreaming. Now imagine if you were in REM sleep and your muscles were acting, you would act out your dreams. If you were Tarzan trying to climb trees, or you were a jouster, you would probably joust your partner while sleeping. So there is a disorder called REM sleep behavior disorder, where the signal to the brain for paralysis of the muscles doesn't happen. And so your grandma or grandpa might act out in their dreams, and beware if this keeps happening, because this is often a sign that they're developing some kind of a neurodegenerative disease, most often Parkinson's disease. Children, babies that are born need almost 18 to 20 hours of sleep. Toddlers and young adults, also teenagers, need quite a bit of sleep. But your average adult ages 20 from college upwards to 64 roughly require 7 to 9 hours of sleep. Anything less than 7 hours, function starts to decline, especially if it's chronic. Older adults, on the other hand, it's very ironic that children have gone away. They're retired now, and they get to sleep less. So they actually sleep 7 to 8 hours. That's all they need. So here's some data on what happens when we don't sleep. And I'm talking about chronic sleep deprivation as opposed to just insomnia. So when you're sleep deprived and only get, say, 6 to 7 hours of sleep, and you're used to 9 hours of sleep, 1.3, just a little about average incidence of crashes. Look what happens when you get less than 4 hours of sleep. Your incidence of car crashes increases by 11.5 increase. Basketball players, NBA players, their performance increases when they get more than 8 hours of sleep and rapidly declines when they get less than 8 hours. Look at obesity and sleep. So this is the amount of sleep hours, and this is the obesity ratio. So as sleep hours decline, you can see that obesity index increases. As a matter of fact, for every hour of sleep loss, it's felt that your BMI can increase by 2.1% chronically. This then takes us to the next stage, which are the sleep disorders. The primary one that I want to be talking about today is insomnia, which is really a perception of inadequate sleep or inefficient sleep. Insomnia is not the same as sleep deprivation, and there are many sleep deprivation disorders, and this is where the danger happens. Things like sleep apnea, if not treated, narcolepsy, or swing shift workers. These are people who are associated with sleep deprivation, and that's where all the metabolic problems of lack of sleep really happen. In insomnia per se, you get minor disturbances, but it's not as bad. They've actually shown it's fairly minor. Sleep apnea and snoring, we'll talk about it just in terms of testing and what can be done. Restless leg syndrome can occur in as many as 10% of Americans, so it's important for you to know this, because if you can treat this, you can sleep better. Narcolepsy absolutely has to be diagnosed and does need the help of a sleep study and a sleep physician to prescribe the medications initially, at least. REM behavior disorder, we talked about it. It's a precursor to neurodegenerative diseases. Bruxism and jaw clenching actually doesn't happen when you're the deepest of sleep. It happens in that stage of as you're getting into wakefulness. So imagine someone with sleep apnea that has somewhere between 100 and 300 awakenings at night. For about 60 to 90 seconds, they're not sleeping, so they're actually coming out of their sleep. These people are the ones that are most likely to have bruxism and jaw clenching, or someone who's very anxious, who's getting into that light stage of wakefulness and going back, will clench their jaws a lot. Parasomnias are very interesting. It's more common in young children who usually grow out of it. When we see it in adults, it's pretty rare. It's almost always associated with drugs. The most common drug that I see associated with parasomnias is Ambien, but there are many of the CNS drugs that are associated with this. And then fatal familial insomnia, we talked about it. We won't be talking about it anymore because you don't live to talk about it. All right, so let's talk about insomnia. Insomnia is not really sleep deprivation, and you have to get this as a take-home point that insomnia is not sleep deprivation. To define insomnia, it's the amount of time you slept divided by the time in bed. So if that ratio is less than 80%, it defines that you are not an efficient sleeper. To make it complicated, when medicine doesn't have a clue as to why we have insomnia, we start to divide it. We've called it simple insomnia, persistent insomnia, primary insomnia. And those three things are essentially the same condition. simple as short, you've had insomnia for a shorter duration of time. Persistent or very hard insomnia is because you've had it for years and it's harder to treat. And both of these are actually primary insomnias, whereas initially we thought primary insomnia was a genetic disorder, but today we know that that's not really the case. Paradoxical insomnia is very, very fascinating because here, if you do a polysomnogram, the patient is actually sleeping 7 to 8 hours, but they do not feel that they're sleeping. So there's a dichotomy in that they think they cannot sleep, but they are actually sleeping. That's pretty much like when I first started meditation. When I started meditation, it's like I would think, I could dream, I could think of everything. So I'm really not meditating. And the more you felt that you were not meditating, the harder it became to meditate. And that's the same thing with paradoxical insomnia. While it's not just something that the person is thinking or believing, it has to be accosted as a true medical problem. And we have to make them see it, but they're at least wanting to see it because it's like, how can it be? Secondary insomnia is truly, it's different from primary in that it has secondary causes. For example, someone who has hyperthyroidism. They're metabolically extremely active. They can't sleep for 3 hours. I remember this happened during my second pregnancy. I could barely sleep 3 hours. I had great energy, didn't gain but 8 pounds till my 8th month, at which time they wanted to put me in bed rest, and all thyroid labs were normal. And it was at that point I decided I'm going to drop my thyroid because I had way too much energy. And lo and behold, within the first week, I gained 5 pounds. So that was secondary insomnia. I didn't think it was insomnia because I loved it. I could get so much work done. So the top 4 problems, sleep science has no clue as to what causes it. And so we don't have a magic pill to make it go away. But here's the good news. This is not the fatal condition. It is. It's not that dangerous. It's not like sleep apnea that is not treated and narcolepsy that's not treated. So in insomnia, it's the attitude about your sleep problem that plays the hugest role in your ability to function well. From Chris Winter's book, I pulled out this slide, and it's very, very interesting because what this is doing is it's talking about the concept of sleep identity. So this does not apply to someone with sleep apnea and narcolepsy. This is only for those who we've identified as having insomnia, that is inefficient sleep. So if you look at sleep identity, in other words, how does a person think? What do they think of themselves? Do they have positive sleep identity or negative sleep identity? We call that low distress or high distress. And then those who say, I have excellent sleep, and those that say, I have poor sleep. So when you look at this group, with the disengaged, you'll see in this slide that those who have poor quality sleep and are low distress, they're disengaged. In other words, they should be feeling higher distress, but they don't. And those that sleep well but have high distress, your classic insomniacs, they also are disengaged, right? But you see that in both these groups, they have the same functionality, which is ironic, isn't it? Take then, for instance, someone who has poor quality of sleep and is low distress, and that one that is high distress. So the patient with low distress and high distress have the same sleep quality, but they have different functionality. This group is more fatigued, more depressed, has memory problems. So this goes to show you that even though the sleep quality is the same, the identity determined whether they had good sleep quality or not. Does that make sense to you? And so that was rather surprising to note that. So what this tells you is that in order to sleep well, you just have to think that you're sleeping well. And the counter is true as well. If you think you're going to be sleeping poorly, you will sleep poorly. And so that's the basis of cognitive behavioral therapy in insomnia, is to teach you how to develop sleep hygiene, how to recognize this pattern, and how to slowly shift this pattern. Briefly, to go to obstructive sleep apnea. This refers to periodic airway obstruction. It can happen in your palatal, it can happen in your the back of your throat because of adenoids, etc. These sleep apneic periods can last anywhere between 60 to 90 seconds. And when it starts to happen 100 to 400 times at night, it's associated with massive sleep deprivation and also low oxygenation to the brain. Symptoms: loud habitual snoring. The snoring alone does not mean sleep apnea. Very unrefreshing sleep, daytime sleepiness and fatigue, memory problems, headaches, high blood pressure, obesity. These are your heavy set people who are not sleeping well, and congestive heart failure is a huge risk in these people. Restless leg syndrome, like I mentioned, about 10% of the population have it. It's likely to be hereditary. This is when you sit down in the evening, start to rest, your legs start to get this crawly feeling like you've got to get up and move. I had a patient who would walk the beat of her St. Charles at night. All the policemen knew her because she would walk literally 2-3 blocks before she can get to sleep. The problem does not lie in the legs. The problem lies in the brain. Remember, all sleep, and you'll know this when we do testing for sleep, has its origins in the brain. Light has to hit the eye. The retina is part of the brain. The suprachiasmatic nucleus sends the signal, and then it maintains the sleepfulness or wakefulness state. So restless leg syndrome, the problem is not in the legs, but the problem lies in the brain. And here it's felt to be some lack of dopamine production, and both dopamine and GABA acting drugs help this condition at very low doses though. Narcolepsy is another extremely serious sleep deprivation disorder. It's characterized with excessive sleepiness and fatigue through the day. Often emotional states will cause them to lose muscle function called cataplexy, and affects 1 in 2,000 Americans. Right now, I have 2 to 3 patients who have narcolepsy. This is one of those disorders that has to be diagnosed with an EEG and also needs the help of a sleep specialist to start treatment with drugs. Drugs that these patients have to be on drugs, just as patients with sleep apnea have to use a CPAP or some kind of a device to keep their airways open. So this takes us to the stage for testing for sleep disorders. Insomnia is a very interesting condition. Let's change reverse roles. I am not the doctor, you are the doctor, and I come to you with chest pain. And I say to you, doctor, I have chest pain. Can I have a stent? What are you going to say? No. Let's take this one step at a time. Let's first get an EEG. Let me examine you. Let me get an EKG. If your EKG is normal, I'll do a stress test. If the stress test is normal, we'll get that cardiac catheterization. That's not true for insomnia. When you go to a doctor with insomnia, you're giving me the diagnosis. It's one of those few conditions where the patient gives the doctor the diagnosis. I have insomnia. There are simple studies, and there are simple tests that you could do, and these are things that you can do yourself if you have a Apple Watch, or you have a Fitbit or a Garmin or any of these smart watches. They record something called, it's not technically an actigraph, but it measures O2 saturation, your pulse rate, and also your movement in bed to determine how you're sleeping. So when you're not moving, remember you're paralyzed, you're in Rem sleep. And when you're moving, you're in either light sleep or deep sleep, depending on how that movement is. So it's not 100% accurate, but it's not bad. It may be as good as a home sleep study. So that brings us to the next study, the home sleep study. And this does record the EKG as well. Insurance companies have resorted to this because it's cheaper than doing a polysomnogram, because that requires like a hotel suite kind of a stay. This study is not good for narcolepsy, insomnia, but it is good to study obstructive sleep apnea. And you could use that diagnostically for sleep apnea. A true sleep study is called a polysomnogram, and it involves three components: an EEG, an EOG, an electro-oculogram measuring eye movements, and an EMG measuring muscle movement, in this case, chin and your leg movements. The data from your polysomnogram can be put into a computerized algorithm known as the Hypnogram, and you can actually see your sleep waves. So let's look at one. Not that you're going to be reading your own, but it's interesting to know what you're looking at when you look at these. It looks like gobbledygook, but it's not. So in this EEG pattern, E1 and E2 refers to the right and the left eye. And you can see they look like they're opposing each other, but they're not. It's just the way the leads are placed, and they happen in opposite directions. Okay, so here you're seeing nice, slow sleep eye movements, rolling eye movements. And these 6 leads are leads on various parts of the brain: the front, the medium, and the back part of the brain. And you can see these fairly fast alpha waves, and you're beginning to see these things called sleep spindles, contractions of alpha waves called sleep spindles. Then chin, left anterior tibialis and right anterior tibialis, these 3 here are muscle recordings. So you can see, like the stock market, you can see data showing that your muscle is fairly active here. Then you get the EKG, and then here you see a snoring pattern, and this goes with the breathing pattern. So breathing in, snore, breathing out, breathing in, snore, breathing out, breathing in, snoring, right? And so the breathing patterns are both thoracic as well as abdominal, and then you also get pulmonary airflow through the trachea. So that's what an EKG is. A polysomnogram is, and this is then computed into the active graph. So when we look at the stages of sleep, in wakefulness, your polygraph is of course beta waves. You're constantly thinking you haven't fallen asleep. Your EMG shows movement. Your EEG shows beta activity, going into some alpha activity if you can calm down. And the electro-oculogram shows some saccadic eye movements like blinks, because you're able to blink. And you're very aware of your external sensation. For example, the sheets, whether you're cold, whether you're hot, whether it's sweaty, you can feel these things. Once you get into that deep stage or NREM sleep, a slow wave sleep, now you can see that the EEG recording is still present, but it's much less. The waves have become tall and slow, and we call these delta waves. And the electro-oculogram is also kind of rolling, steady eye movements. You cannot feel any sensation. You're dull. So if I touched you, you're in deep sleep, you won't know it. REM sleep is quite different. Look at the EEG here. It's completely flat. There is no muscle movement. You're paralyzed. If you ever woke up from REM sleep, you might remember you can see the person, but you cannot move. It's almost scary for about a few seconds, and then you can slowly start to move. EEG is beginning to show activity just like you were in wakefulness. And the electroencephalogram is showing these fairly rapid saccadic eye movements. A lot of sensation, but you cannot feel external sensation. It's internally generated because of your dreams. They're vivid dreams, and you can have sensory experiences in these dreams. All right, so now we go into the last phase of our webinar, and that is the treatment for the various sleep disorders. So here always starts with good sleep hygiene and sleep habits. And I'll talk about managing circadian rhythms, correcting sleep apnea if that's the case with either oral or CPAP devices. And we'll talk a little bit of napping and sleep debt, because I get asked this question all the time. We'll talk about some supplements that are widely used and what we use here at Palm, the role of prescription drugs, and cognitive behavioral therapy. So without further ado, I'm not going to read every one of these, but because they're available for you in the webinar. So the first thing is to create a nice hibernation space, so kind of a lair, a clean, uncluttered bedroom. I have real problems with my son who keeps his bedroom. He never makes his bed. You know, it's like, why do you need to make up your bed? You're going to get up and go back to sleep again. Well, he suffers from, I believe, paradoxical insomnia because I've seen him sleep, but you can't make him believe that. I've shown him that in studies when rats are kept in a cluttered environment, they don't sleep. If you darken the room, keep no alarm clocks, keep your cell phones off, you're more likely to sleep. No noise, no TV. Remember, you spend about 1/3 of your life, your 24-hour cycle in bed. So get a good, cozy, comfortable mattress and get some expensive sheets that you like, because that's 1/3 of your life. Take the time to find your perfect pillow, even if you have to go through 8 iterations to do so. The third one is a dicey subject, but I constantly talk about it with my patients. You have to manage yourself and your spouse, and sometimes therapy might be important. If your spouse is a limb mover and trasher and wakes you up and you're a light sleeper, this is not going to work. You might schedule time apart and time together, you know, like sex time together, and then you're out. You're sleeping in separate bedrooms. Definitely kick some habits. No nicotine, minimize alcohol in the evening, because alcohol actually gets you awake in 5 to 6 hours. And if you are suffering from insomnia, avoid caffeine. Caffeine and chocolate are extreme disruptors of adenosine. They actually block the adenosine receptor. So your adenosine can climb, but it has no place to latch onto to create that urge to sleep. Definitely don't eat 3 to 4 hours before bedtime, because when you feel full, you just don't feel like going to bed, or you might get reflux symptoms. It's helpful in your last meal of the day to actually add a healthy carb. Carbs actually send a signal to make serotonin, which can actually help with sleep. If you've ever put children to bed, there's a crazy routine you have to go through, and unless you go through that routine, these kids don't go to bed. And this could take about an hour to an hour and a half long. And similarly, you too should plan on such a routine, not quite taking 1.5 hours, but to get into that preparation phase where there's no blue light for an hour. That means no television, no iPhones, no iPads, no computing time. Get into a warm bath, get into comfy clothes, brush your teeth, you know, keep your sheets cool. If you need to have a warm bath about an hour or so before bed, so you're not sweaty. And if you do all of this and you still cannot sleep, then there are programs out there. They are biofeedback programs. One of the better ones out there is called Muse 5 Gen 2 for sleep. It's about $400, and it's a pretty cool device. I've not really seen it, but I learned about it in Chris Winter's book, where it's an EEG. So it's a band which is very comfortable that goes on, and it measures your EEG. And so let's say you're on beta activity, you're not able to shut down. It synchronizes that beta activity to, say, the sound of an ocean or a forest, where it's nice, slow alpha waves, making it easier for you to fall asleep. And apparently you wear this for 4 to 6 weeks, and then you may not need it. And then if you need to go back to it, you can go back to it. Finally, the bedroom is only for sex and sleep. So anything else you do in your bedroom should not be done in the bedroom. All right, to manage circadian rhythms is another big aspect of sleep, because it's not just rhythms, but it's not just the drive to sleep, but it's also those rhythms. So get exposed to sunlight. When you wake up, within an hour or so, get out and see sunlight. If you can't, then get a 10,000 lux energy light. Sorry, that's a typo. That should be lux. And there are various lights available for someone who really feels they need much more light in the winter months. Fairy flux, northern lights, if you travel a lot, like Foria. As we get older, we tend to nap early and then and go to bed really early. So if your phase advanced, meaning we go to bed early, then you should try and get sun around 2 to 3 p.m. because it can postpone bedtime till about 9 p.m. So you don't get up at 3:30, 4 in the morning. For people who go to bed late, try getting sun early in the morning because about 14 hours after you get sun, you're getting your desire to go to bed. If you must compute at night, watch Netflix, use cheap orange UV blocking glasses, or I use these glasses which already have UV blocking for computer blue blocking lenses. But since they're only reading glasses, when I'm outside, I don't need to be wearing them. And when I'm sitting out in the sun or sitting at Palm's patio for lunch, I don't need to wear my glasses. Install Flux or dimmer. Most of our iPhones already come with this. Our computers may come with this, and all you have to do is turn it on so that at night at 8 o'clock, it already dims the light. It's not a perfect solution, but everything you can do to help yourself will make a difference. It's important to maintain your daily schedule. So remember, I said it's not just light that entrains circadian rhythms. It's also entrained by when you eat your meals, when you exercise, when your first social interaction is, when you poop, when you pee. So keeping those things very regular is important. I said I would talk a little about napping. Napping is an interesting subject. So the key thing about napping is if you remember the hypnogram, you do not want to get into N3 sleep, that is into deep sleep. So it's best to nap for between 15 and 30 minutes before you get into that deep sleep. Once you get into deep sleep, you're going to disrupt your nighttime sleep. Napping is also easier if you're an early morning waker. Let's say you want to wake up at 4 o'clock and exercise, then it's best for you to try to take a light nap before lunch. But if you're one of those that gets up at about 9 o'clock or so, then a nap time around 1 or 2 o'clock is better than taking it too early in the morning. Sleep depth. You cannot cover sleep depth unless it's acute. So recently, I traveled to Florida for my brother's 60th birthday. That weekend was daylight saving. So not only did I lose an hour by going east, but I also lost another hour with daylight saving. And then I came back the day after daylight saving to St. Louis and gained 1 more hour. So my whole rhythm was kind of crazy for about a week. It took me literally a week. And so for 3-4 days, I had to sleep almost 10 hours a night to correct my sleep. And that's correcting sleep debt. But you cannot correct chronic insomnia. So you have to know that this is something that you do quickly and chronically. You want to manage blue light. So these are all different things that you can read on your own. Cut down alcohol, cut down caffeine, and cognitive behavioral therapy is one of the most effective treatments for insomnia. It requires that you have faith in the system. You believe that you can control your sleep. And I need to make you understand as a physician, and all of us physicians at PALM will do that, make you understand that that's the only way to truly make the change. All right, so you've corrected your sleep habits, you manage your circadian rhythms. So if you have sleep apnea, these need to be treated with oral or CPAP devices. We talked about napping and sleep debt correction. So let's go to supplements now. Supplements can be divided into those that control anxiety, herbs, and also hormones for sleep. And then some of the therapies which we here use at PALM. So for sleep, the simplest one, magnesium glycinate or magnesium glycinate threonate. At PALM, we call this PALM Mag and NeuroMag. CBD is another excellent choice, and you have to find the dose that works for you, anywhere between 10 milligrams and 200 milligrams. It could be used as a gummy, as a sublingual. I personally like the sublingual because it doesn't have any sugar. L-theanine is used at doses 200 milligrams, and it works on the excitability receptor of the brain, and is very very synergistic with magnesium. Multiple botanical herbs that contain valerian, kava, passion flower, chamomile can help. We have one here called Botanical Calm, PM, that we use. Serotonin precursors are particularly helpful for those who suffer from seasonal affective disorder. And these can be either tryptophan up to 2,000 milligrams or 5-HTP starting at about 50 milligrams. GABA containing supplements can also be very calming, but they don't work long term in my opinion. After about a month, the body gets used to GABA and downregulates it. Glycine and taurine are two amino acids. They're non-essential amino acids, but they're extremely calming and also help with detoxification. And then if you still can't sleep, there's Muse Gen 2, which is a biofeedback device. Herbs, valerian, and you can get this as teas. You can get chamomile tea. Chinese magnolia or velora is good for disengaging for stress and helping the hormone cortisol. Melatonin, the studies are not great, but if it happens to work for you, please, by all means, use it. I see melatonin as setting the stage for sleep, but remember, it's not just the eyes that see light, the skin can see light. So if the skin sees light, your melatonin can be destroyed. So it's important to keep your room really dark. DHA is an oil, fish oil or algal if you're a vegan, has DHA. DHA is the fat that can engage light on the receptor of the cell. And so it's very helpful for brain function. Some of the therapies that we offer are sound refocusing, very similar to it, various white noise machines that are out there that you can get, biofeedback. It's kind of like the Muse, but it's a little different because ours uses more of acupuncture meridians. PEMFMAT can help immensely with stress reduction. Biomet is also helpful for natural energy frequencies in your body. Cryo is fantastic for beating jet lag. So if you ever travel a lot, then come and get a cryo and get into the sauna or get a massage or do any of the treatments that help you with sleep, including biofeedback. If you have anxiety, not only should you do cardiac coherence, you should practice it, because just doing it occasionally at home doesn't cut it. You really have to practice the breathing techniques and gratitude that you feel. It would be remiss of me not to mention NADs. I don't want you to come and use NAD IVs for sleep, please, but it is an anti-aging tool that can help if you occasionally use an NAD IV, more as part of the anti-aging tool, because as we get older, we can replete NAD. If you're young and have insomnia, it's better to address anxiety, but if you're older and have insomnia, it's something to definitely talk to your physician about. Drugs. So drugs, hot topic, but also a very contentious topic when it comes to the treatment of insomnia. Over-the-counter remedies are all antihistamines. Doxylamine is Unisom, a form of an antihistamine. Benadryl, hydroxyzine, these are all available over the counter. Short-term, not a problem. Long-term, it has anticholinergic effects and so can lead to dementia. Melatonin in studies has not been found to be useful, but again, if it's useful for you, by all means use it. Benzodiazepines block NREM. So remember, NREM sleep is a deep restorative sleep, slow wave sleep. Sedation does not equal sleep. Sedation is CNS depression, and it can be very, very addictive. So long-term use is not recommended. Unfortunately, I do have some patients, once they get on it, it's hard to get them off. Ambien is also a CNS depressant, so it doesn't lead to good restorative sleep, but it does give you a feeling that you have got that much time in bed. And so again, cognitive behavioral therapy for insomnia, called CBI, is paramount to slowly get you off Ambien. Ambien is one of those few drugs that are associated with parasomnias, sleep eating, sleepwalking, sleep sex, etc. Sonata is very similar to Ambien. It's used for short-acting for people who have difficulty falling asleep. Lunesta is another non-benzodiazepine, but it's used for keeping you staying asleep. Again, short-term use. Resveratrol is a melatonin agonist, and kind of like melatonin in the studies, it was initially impressive, but in the studies doesn't show much benefit. A newer kid on the block is called Varsha or Civorexant. It's an orexin. Remember the gene for wakefulness, orexin? So it inhibits orexin. Well, narcolepsy is a problem that occurs in the orexin gene. So when you take too much Varsha, you can actually develop drug-induced narcolepsy. Tricyclic antidepressants such as Elavil, doxycycline, amitriptyline can all have grogginess as its side effects, and therefore they're used for sleep medication. But they're also anticholinergics, and so long-term can lead to dementia. I have 2 patients on antipsychotic drugs for insomnia, but almost all studies, they're off-label use, and they generally tend to have bad outcomes. Weight gain is a huge issue. Here's a chart for the history of using sleeping pills and your risk of death. So even at just 18 sleeping pills a year, your risk of death, odds of death are 3 times higher. And when you get to half the year of using sleeping pills, you have a 5+ higher risk of death. So where are drugs useful? Restless leg is one of those, when I fully diagnose, it's not a diagnosis that needs a polysomnogram once you diagnose it. I like dopaminergics, but of late I've been starting to use gabapentin and pregabalin if the insurance companies will allow for pregabalin. These are much safer than ropinirole. The dopamine-containing drugs can actually lead to dopaminergic effects such as addiction issues, etc. If you're a shift worker, first, I would encourage you to change your job, but if you must continue your job, then you might require a sleeping aid and some light therapy as well. Narcolepsy absolutely needs treatment for life. There is no getting off of these drugs, but they do need to be evaluated so many years for sleep studies. Anybody with insomnia who is experiencing an acute event, such as the death of a spouse, medical illness in the family, extreme stressors at work, definitely consider calling your primary care and have an end goal. I want it for 1 month, 2 months, so no longer than 3 months for the treatment of insomnia. Some axioms for insomnia that I would like to share with you is achieving good sleep is like trying to work out and you've never worked out in your life. It takes a while to build muscle. So the longer you've not slept, the harder it is to learn to get to sleep, and just be aware of it. See insomnia for what it really is and for who you are, meaning what is your sleep type, what is your insomnia identity. Type A personalities, people with OCD traits, people who tend to have anxiety, tend to be much more caring about their ability to sleep, right? Like for me, I mean, if I don't sleep a night, I'm okay. I know I'm going to be okay. I think residency taught me that, where I would go 36 hours not sleeping and still function quite well. So if you have that attitude, you're more likely to sleep. But if you have the attitude of caring so much that you really should get to sleep, then you won't do very well. So when it comes, I also tell patients to think about the top 100 causes for death. Insomnia is not one of them. Untreated sleep apnea is, untreated narcolepsy is, but not insomnia. So it's not as big a deal as you think it is. And basically, insomnia is fear, kind of a post-traumatic stress syndrome, because you learn to your core identity becomes that of insomnia. You know that you're going to get into bed and you're not going to sleep. And when you know that, it's going to foster the condition. And if I suddenly challenge this, then you're not going to like it. And so that's part of the problem in treating insomnia. And therefore, it's really helpful to develop a good relationship with a therapist who can actually walk you through a 6-month to 9-month program where you can learn some good sleep hygiene techniques and take it to faith and practice it. These are the same things that I've talked about. You can watch this at your own time. I thank you so much for participating in this webinar. I certainly had much fun preparing for it, and I hope you enjoyed it as much as I did. Thank you so much. All right, so this ends our webinar. If any of you do have questions and want to know more, please contact PalmHealth at palmhealth.com, and we will be happy to answer your questions for you. Again, I thank you for coming to this webinar.